I'm going to just start out by giving the land acknowledgement statement. So recognizing the land that the University of Washington sits on. I'm recognizing that we're all on Zoom, so we actually may be in different places, but hopefully this statement kind of covers most of our geographic locations. All right, so in terms of things that I'm going to talk about, I'm going to spend a very short amount of time giving an overview of health equity just to make sure that we're on the same page and kind of level set. Then I'll focus on defining and describing the limited English proficiency population. And then I'll talk about the barriers to equitable care for this population, again, focusing on those with serious illness as well as their families. And then I'll kind of end with a section about strategies to provide equitable palliative care for patients with limited English proficiency and their families. Okay, so as we think about health equity, a lot of times people talk about these terms, diversity, inclusion, and equity kind of all together. And I just wanted to take a minute to kind of separate out those terms so that we understand the role of each of those things. And then again, this talk is really going to focus on the equity aspect. So I really like this quote as a nice way to kind of understand these related concepts. So you can think of diversity as a fish solution, right? So bringing different types of fish, as you can see in this picture here, to the tank is diverse, right? But it doesn't create better pond conditions for all the other fish. You need inclusion to hear what specific types of fish need, and then implementing those structural changes to the pond itself should be the focus of equity-based work. So as we think about the healthcare system, that's the place in which I practice, how can we make the healthcare system a place where everyone has equal opportunity to achieve optimal health and to receive optimal health care? And that's really the role of equity. So we need all three of these things. And as I said, I'm going to focus, though, on the third piece. Many of you, if not all of you, have seen this picture or a picture like this, which kind of shows the evolution and how we've thought about these concepts. So in the past, literature really focused on evaluating differences, right? So we would talk about health disparities. And the idea was that we wanted to make sure that everybody had the same outcomes. So if they were not having the same outcomes, in other words, if they were having health disparities, then there was a problem that we needed to address. But you can see that if we think about everybody having the same intervention or the same outcomes, there's a problem, right? It's not recognizing the fact that not everybody starts from the same position to begin with. So in this picture on the left here, you see that if you gave everybody the same sized box to stand on with the idea that you wanted all three of these people to be able to watch this soccer game, right? That's the outcome that we're talking about in this picture. It doesn't achieve that outcome. So for the person for everyone, for the person on the left who could already see over the fence, that extra box kind of helped them see extra well. For the middle person, it was helpful. She's almost able to fully see over the fence. And then for that third person, it's not helpful at all, right? That third person needs something different than a box. So this thinking, this recognition that not everybody is starting from the same point because of things like structural racism and other systemic barriers to kind of equity, we've started to talk about equity. In other words, if the goal is to help everyone achieve that same optimal outcome, then we need to think about for different people, what is the intervention that's needed to achieve that goal, right? So this person in the middle actually needed 2 boxes, the person on the left didn't need any boxes, and the person on the right needed a ramp. So that really, I think, kind of frames the current approach, that we're recognizing that people are not starting from the same point. And so we need to think about different solutions for different people so that we can achieve that end goal. I'm not going to spend much time on this at all, just to say that, again, as we're talking about why doesn't everybody start from the same place, it's because of these things like structural inequities. social determinants of health. You can see many of those listed in this figure here on the right. And then disparities that are occurring in the healthcare context, which is, again, kind of the focus of my work and what I'm really going to speak to today. And here we're thinking about things like clinician behavior, as well as health system level factors. Okay, there's a lot going on in this slide. The purpose of this slide is just to illustrate that as we think about inequities for patients with limited English proficiency in the context of serious illness care, we're looking at multi-level barriers that are occurring. So we have personal barriers, you can see in this kind of first column, which includes things like demographic characteristics, literacy, knowledge, attitudes, and beliefs. Again, since we're talking about serious illness, we're talking about things like their knowledge and attitudes of palliative care, of hospice, acceptability of those types of services, preferences, health behavior, etc. Then we can think of the structural inequities that are there related to accessing care, right? How care is organized, can people even get to care? There are financial barriers, and there are societal barriers as we think about the role of historical discriminatory practices, things like redlining, for example. And then there's these healthcare mediators, right? So now we're talking again about the clinical setting. And so we've got barriers at the clinician level. So things like, does the clinician have competent skills in dealing with, cross-cultural communication, for example? What about communication skills in general as we think about serious illness, goals of care conversations, et cetera? Their medical knowledge, their technical skills, things like implicit bias. And then the provider or clinician is bringing their own characteristics as well. That may also influence the clinical encounter. And then you can see that kind of all of those things then affect the delivery of care in the context of serious illness and end of life as we think about palliative care, hospice, acute medical care, so care that people are receiving in the hospital, how intense that care is, the duration of that care. And then at the far right there, you can see that types of outcomes that we look at in the context of serious illness, thinking about things like quality of life, goal concordant care, et cetera. So I think this gives you kind of a general overview of the fact that there are many levels at which barriers are occurring to care. And as I mentioned, though, I'm going to focus on that clinical encounter for the most part. Okay, so who are we talking about when we talk about those with limited English proficiency? There's the US Census Bureau definition. So for US Census materials, people are asked to complete how well they speak English, and the choices are very well, not at all. Limited English proficiency is often categorized as all the responses below very well. So all of the people who say that they speak English less than very well. An alternate approach to kind of identifying who we're talking about here in terms of LEP is an approach that's often used in the health system, which is to identify people's preferred language for medical care. This is the language for the question that's asked within UW Medicine. What language do you want to talk to your healthcare team about your care? And so for any responses that are not English, we would consider that group of people to have limited English proficiency. And in this work by Carliner and colleagues, they actually looked at comparing these two approaches, the census level definition, which you can see kind of highlighted there, as well as this question of preferred language. You can see that in general, both of these approaches capture the majority of people that we would identify as having LEP. Whoops. But there are some slight differences depending on what approach. And so again, within the health system, we are often focusing on the preferred language. All right, so as we think about what languages people in the US are speaking other than English, that's changed over time as it kind of mirrors the changing demographics within the US. So you can see the list of languages there on the left, starting out in rank based on 1980, and how those languages have changed over time. So those that are highlighted in the red boxes are the most frequently spoken languages other than English in the US as of 2010. So those continue to change, but you can see that as we think about Spanish, as well as several Asian languages and French kind of rounding out the top 5 there. So keeping in mind those changes that I just showed you in terms of which languages are spoken by a larger proportion of the population, in this slide, you can see English speaking ability based on the US Census Bureau definition for some of these different languages. And so less than very well would be orange, green, and purple, right? So the colors other than blue. And you can see as you go towards the bottom here, you see the languages where you have the highest proportion of people with limited English proficiency. So you can see that when we get down to Korean, Chinese, and Vietnamese, that actually more than 50% of those populations have limited English proficiency. And again, kind of highlighting that these are also some of the languages that are now being spoken by larger proportions of the population in the US. As we think about kind of where in the US we can find the LEP population, you can see here, this is data that was looking at those with Medicare or Medicaid or dual beneficiaries. Those states in dark blue are the states with the highest proportion of LEP population. So you can see that's the entire West Coast, as well as then some of the East Coast, South, and then kind of some states there that are in the middle. Oops. As we look at Washington there, you can see that Washington makes the list of the top 10 states in the US with proportions of LEP populations. And so I think that's why this topic is particularly relevant to those of us who are practicing here, thinking about the local communities that we're serving. It's probably no surprise that California, New York, and Texas and Florida are kind of the top 4 states as we think about LEP populations. Again, this is focusing on adult population. When we look at Washington State itself, this is data from 2013 that showed the foreign-born population in the state of Washington being just over 1 million. 44.3% of that population has limited English proficiency. You can see among the US-born population, which makes up almost 6 million in the state of Washington, there's also a small proportion, about 1%, who report LEP. That brings our total LEP population to over 500,000 in the state of Washington. In the pie chart, you can see the distribution of languages. You can see here that these languages do kind of mirror some of those most frequently spoken languages in the US as a whole. So for our Washington state population, almost 50% of those with LEP are Spanish speaking, followed by Vietnamese and Chinese. And then we have Korean, Russian, Tagalog, as well as the African languages, with many other languages making up that other 20%. So we see a pretty diverse population as we think about those with LEP here in the state of Washington. Okay, so now I'm going to turn to some of the data that we have about healthcare outcomes for this population, again, focusing on the context of serious illness. So I want to start by mentioning that when we think of the national standards around healthcare, the principal standard here is that to provide for health systems to be providing effective, equitable, understandable, and respectful care care that's responsive to diverse cultural health beliefs and practices, languages, health literacy, and other communication needs. And that there is a requirement for health systems to offer language assistance to individuals with LEP at no cost to themselves, as well as to ensure the competence of individuals providing language assistance, recognizing that the use of untrained individuals and or minors as interpreters should be avoided. I think that seems like common sense, I would say, in that we should not be relying on family as interpreters. And yet, as I'll show you with some of the data, we do that all the time, as well as actually not using interpreters to the extent that we should be. So this is the kind of standard. And as you'll see in these next few slides, I'd say we're well away from achieving that standard. So this study was looking at use of interpreters for hospitalized patients. So this is one of the few slides I'm going to show you that is beyond serious illness, and it's talking about all hospitalized patients with LEP. As you can see here, they were looking at whether interpreters, and that was any kind of interpreter. They broke it down by whether it was a hospital interpreter, whether it was a family member, whether it was a nurse or physician. So interpreter not present means none of those other people were present. They looked at whether an interpreter was present with the physician at the time of hospital admission, with physicians during the hospitalization, as well as with nurses during the hospitalization. And you can see here that 43% of patients did not have an interpreter present at the time of their admission to the hospital in their visit with the physician, with the admitting physician. 40% had encounters during the hospitalization with physicians where there was no interpreter present, and 63% of patients had visits with their nurse, the bedside nurse, during the hospitalization, during which time there was no interpreter. Again, this is not even a family member present. So why do we see that pattern where people are not using interpreters to the extent that we just talked about they're supposed to? So in this qualitative study that interviewed residents, this resident says, I know that when people are pushed for time, they may or may not call an interpreter. They may just get by on the few words they know in different languages for things like pain or take a deep breath and just fumble through. This other resident says, I feel guilty because I feel like I'm not doing my job. It also makes me feel frustrated and upset at how our hospitals and clinics are run that we allow this to happen. There's a lot of sentiment that, well, maybe patients with LEP shouldn't be getting healthcare. I think the reason that I feel badly is because I know that I'm not giving equal care to my patients. So here you have the recognition that patients are not getting equitable care, and kind of, I would say, a combination of clinician level and system level factors, right? Barriers to the use of interpreters. So here you have the recognition that people know they need to be using interpreters. And yet, because of these clinician and system level behavior barriers, that's not always happening. In this review of, now this is focusing on palliative care population specifically, you can see that in the systematic review, the authors found multiple studies showing that providers frequently relied on family, including minors, to interpret information about diagnosis and prognosis. That when professional medical interpreters were not used, patients and families had an inadequate understanding of diagnosis and prognosis. Patients had worse symptom management at the end of life, and families experienced emotional conflict and psychological distress, particularly when they were the ones providing the interpretation. In similar work, now this is data where they interviewed interpreters. Interpreters talked about how palliative care jargon, things like DNR, hospice, those kinds of concepts were really hard to translate. So even if there were actual words in the other language for these terms, those words didn't necessarily have the same meaning as the terms do here. So that was really a challenge. Interpreters reported rarely receiving feedback or being able to debrief with teams after a discussion. Again, we're focusing here on communication that's occurring in the context of end-of-life care. And that interpreters reported a conflict, oftentimes between strict interpretation as well as between using cultural brokering. In this study that focused on oncology patients, and here this is an Australian study where they were looking at the local population, immigrant population, and immigrants used interpreters and then did not have interpreters present. Oncologists used more medical jargon with immigrants, with interpreters, and made fewer statements of hope. 23% of prognostic statements made by the physician were not interpreted. Now we're talking about just the subset of conversations where an interpreter was present. 27% of interpreted physician statements were not interpreted accurately. 59% of patient and family member prognostic statements were not interpreted. And you can see some sample quotes here from that study. Here the physician says, "We think there's a 40% chance that the treatment will prolong your life." The interpreter translated that to "the treatment will prolong your life." So they dropped off that part about the 40% chance. And in this quote, the physician says, "But you have a reasonably good chance to respond to the chemotherapy, and therefore I should be able to control this cancer for months and months." The interpreter says, "But you have a great chance that if the chemotherapy works, the disease should be under control and your life should be able to be prolonged and prolonged." So here we have a substitution happening for months being turned into prolonged and prolonged. So really changing the meaning of what was intended there. In data from ICU family conferences, this is from Harborview Medical Center. Here, this data showed that the length of ICU family meetings was actually not different between discussions where there was an interpreter and discussions where there wasn't an interpreter. So what that means is if the discussion overall, the length was about the same, then recognizing that there's some time for the interpreter to be interpreting, it suggests that other things were being cut out here. And indeed, they found that fewer clinician statements providing support to families occurred. So these were the kinds of things that physicians cut out of discussion. Statements valuing family input, statements easing emotional burdens, active listening techniques. Furthermore, in looking at the subset of conversations where there was an interpreter, they found that alterations occurred frequently. Now, some of these alterations had the potential to positively affect communication. So here you can see in this quote, the doctor says, "I don't know what else to say to you. I mean, I told you yesterday that he's essentially brain dead. I don't know what you expected from that. I also said yesterday that there's no recovery from this." The interpreter, kind of trying to soften that a little bit, says, "I told you that his brain was dead and it wasn't going to recover." However, the majority of alterations had the potential for negative consequences. So here we're talking about affecting things like information disclosure, treatment decisions, emotional support, rapport, and the interpretation of questions. So some of the quotes that kind of illustrate that, the doctor says, "I don't know, this is a very rapidly progressing cancer." And here the interpreter changes the meaning. "He doesn't know because it starts gradually." The physician here says, "Have you spoken to your husband about these kinds of questions before he got sick? What his wishes might be in this sort of situation?" The interpreter translates that to, "Did you talk to your husband before he got so sick about possible situations, what was awaiting him?" So the doctor's intention there was to kind of explore advanced care planning, but that message didn't come through in the interpretation. And then here we have a family statement But what we want to know is that after his lungs get better and when he wakes up, will his brain suffer and affect his ability to recognize people? The interpreter says, okay, she wants to know about the lungs. When he wakes up, so about his lungs. And what about after? So it will not affect him. So again, here the meaning is really getting changed by the interpreter in that context. Okay, so as I think about kind of the key takeaways from that section, I really want to emphasize that we have a lot of data that shows that we're not using interpreters enough when we should be. That without using interpreters, patients are at risk for poor outcomes. And that sometimes, even when we do use interpreters, patients may receive poor quality care. And I'll talk a little bit more about that again in the section on strategies. Okay, so we talked about use of interpreters. Now I want to kind of briefly talk about some of the outcomes we know in terms of decision making and what's actually occurring at the end of life. So in this study from the Mayo Clinic, they were looking at patients with LEP in the ICU setting and looking at outcomes there. You can see that patients with LEP were more likely to receive mechanical ventilation. They were more likely to have restraints used. And they were less likely to change their code status from full code to do not resuscitate. When they did change code status to DNR, it took longer. They were also less likely to receive comfort measures order sets. If they did transition to comfort care, you can see it took much longer, so a median of 19.1 days longer. And of course, they were less likely to have advanced directives. And that really, I think, echoes a lot of the literature for racial and ethnic minority populations in general. And I would say, you know, as we think about a lot of this, we're seeing that same trend where minority populations tend to receive higher intensity care at the end of life and are less likely to complete things like advanced care planning. Here's data from UW Medicine. This is actually data that I'm currently working on, which is looking at older adults, so patients who are 65 and older who received care through UW Medicine and died between 2010 to 2018 with at least one chronic life-limiting illness. So here we're comparing those with LEP versus those with English proficiency. You can see the statistically significant p-values are the ones that are bolded in black. So patients with limited English proficiency were more likely to have emergency department visits in the last month of life. They were more likely to die in the hospital than those with English proficiency. They were more likely to have 30-day readmissions. So that was looking at the last 90 days of life. And they were less likely to have any kind of a healthcare directive or POLST form in the EHR. And to give you a sense here, when we're looking at utilization of care in the last month of life, you can see that just under 14% of patients with LEP had a palliative care consult, compared to about 9.8% of those with English proficiency. And then there you can see the numbers for healthcare directives as well. So among those with LEP, about 36% had completed or had documented directives in the EHR, and about 39.5% of those with English proficiency. So I would point out that we're seeing, in general, a relatively small proportion of patients who received a palliative care consult in the last month of life, whether or not they had limited English proficiency. And similarly, you know, kind of less than 40% of patients, again, regardless of English proficiency, with a serious illness who had completed advanced care documents. So I think, you know, one takeaway from this slide is that there's an opportunity to improve care for the full population And then, of course, here we see that for certain outcomes, those with LEP are more likely to receive intense end-of-life care. And of course, the question is, how does that map to their preferences? And I'll talk about that in a minute. And then just briefly, we see kind of the same patterns play out even in looking at data from Canada. So here, this was a very large data set where they looked at utilization of care in the last 6 months of life. Recent immigrants had more hospitalizations, ICU admissions, mechanical ventilation, dialysis, peg tubes. So, you know, a wide variety of high intensity care. And then this map shows the relative risk of dying. So again, this is a decedent population, right? So we're looking at patients who all died, but how intense the care was that they received in those last 6 months of life. The darkest blue on the map represents the regions that had the highest relative risk of dying in the ICU. So here you can see the darkest blue is South Asia. So that's the Indian subcontinent and its neighboring countries. You also see darker blue in Africa. And then the blue kind of becomes a little less dark as you look at other parts of Europe, other parts of Asia, South America, etc. Again, I think this kind of reflects some of the immigration patterns for Canada specifically, but I think it's really helpful as we think about, again, some of our immigrant populations here in the Pacific Northwest. Okay, so again, I would say not surprisingly, and in line with what we see for other racial ethnic minority groups, patients with limited English proficiency are more likely to have high intensity end-of-life care. Okay, so I mentioned that I wanted to kind of touch on this piece about preferences. So as we see that pattern of high intensity end-of-life care, and we think about our ideal outcomes, one of which is goal concordant care, right? So care that's aligning people's values and preferences with the care that they're receiving. And so I think a question when we look at the data that I just presented is, well, what if that's the care that people wanted to receive, right? In terms of high intensity care. So in this study, people were presented with some hypothetical scenarios related to serious illness and then asked about their treatment preferences. And what's highlighted here in this red box is that for those participants who reported English as a second language, and then you see they had a large number who were Spanish speaking, so they kind of pulled Spanish out separately, that we see really high numbers there in terms of the proportion who said they were uncertain about their treatment preferences. So you see 83% of those who reported English as a second language and were not Spanish speaking said they were uncertain about their end-of-life treatment preferences. 63% of Spanish-speaking participants said they were uncertain, compared with only 31% of English-speaking participants. And so I think this raises the question of, is some of that high-intensity care that we're seeing actually not reflective of treatment preferences, and that there's a role for communication to help really understand what type of care is in line with what's important to people. So kind of similarly, as we look at hospice, and again, we have plenty of data that racial ethnic minority populations underutilize hospice or are less likely to utilize hospice services. In this study, Chinese, Korean, and Spanish-speaking participants were asked about their attitudes, familiarity with hospice. And so what I think is interesting to note here is that we see some differences between languages, but then we see some common patterns as well. What's highlighted in the red box here is the proportion of people who said if their family or friends were seriously ill, that they would tell them about hospice services. And the bottom question there being, would you like to receive more information about hospice? So when we look at the Chinese speaking group here, 94%, right? That's almost everyone who said that they would tell family and friends about hospice services and would want more information. You see slightly lower numbers there for the Korean population. So of the three groups, Korean speaking participants, 74% said they would want to have more information. When we look at Spanish speaking, you see that 75%. So here we have kind of the lower number would tell their family about hospice services, but the vast majority would want more information about hospices. So, 2 points here. One, that actually we see a really high number of participants from these three specific, language groups expressing a desire to have more information about hospice and an openness to kind of wanting to talk about hospice. And then this also highlights that there are differences between each group. So I've been talking about LEP, kind of the role of language barriers as kind of, grouping these distinct and different communities all together under that overall heading. And so, yes, I think it's really important to acknowledge that there are differences between these subgroups. And then there's some common elements to having English not be your primary language that affects the way in which you interact with the healthcare system and clinicians. So some things that are unique to groups and some things that are common to those groups. Okay, so what I wanted you to take away from this section was that we see this pattern of high intensity end of life care, that may not only reflect a desire to have that care, but rather that may highlight opportunities for us to improve the way in which we communicate about end of life care and serious illness, and how we support patients and family members in the decisions that they make. That there is a desire among many of these subcommunities to learn more about hospice, so that there's likely a role of a lack of knowledge about hospice. That is one factor that's likely contributing to the lower rates of use of hospice. And then, as I was just talking about, right, recognizing that yes, differences do exist between different communities. And so there's also a role for us to understand what some of those differences are. Okay, so now I want to turn to, so now we know that this population is not getting optimal care, right? There are inequities in care. We've talked about the issues around a lack of use of interpreters, how they're getting high intensity care, that care may not actually reflect what's important to them. So how do we really think about providing good care, high quality care for this population? So, and this builds from the data I just presented. First, we need to think about assessing the need for an interpreter, right? So basic points here. Check the medical chart to see if the patient, and now I'm talking about within the health system setting. Check the medical chart to see if the patient has indicated a preference to receive medical care in another language, right? If so, that's an important tip-off. Ask the patient or family member if they would prefer to speak in their native language, right? And again, as we're thinking about serious illness, and we're thinking about conversations on really complex concepts that are not as easy to understand and require high levels of medical literacy, it's particularly important to think about these issues. Some things to think about as we're thinking about, when to bring in an interpreter. Being conversational in English may not be enough to understand medical jargon. Again, as we're thinking about things like goals of care discussions that are really hard to understand, even for those who are fluent in English, I would say to have a low bar for thinking about the role of an interpreter in any kind of conversation like this. And one strategy there is to really normalize the need for an interpreter when you're talking with the patient and family, because you're talking about complex concepts, right? So it's not just about being fluent in English. There is also that health literacy part that is going to play into people's ability to understand these really complex concepts. You know, a question I'm asked frequently, I would say, and comes up a lot is, well, what about family members who want to be interpreters, or not just that they want to have that role, but they actively resist when you're suggesting that we bring in an interpreter, whether that's the idea of they don't want a stranger in this conversation, or whether they feel they don't need an interpreter. You know, what are some strategies for handling this kind of challenging situation that comes up, where as a clinician, you recognized that there is likely a benefit to having an interpreter there. And so I like to, this is a little bit of a long quote, but I think it kind of outlines a really nice approach. So this is from a study where we're looking at the Harborview Community House Calls or Cross-Cultural Mediators Program. I'm going to actually mention them in a little bit. And we interviewed cross-cultural mediators about their perspectives in thinking about caring for patients with LEP. And I thought this quote highlights so nicely an approach to answering that question that I just raised. So I'm going to kind of read this whole quote. So the CCM says there's also a group that feel they're independent and they don't need an interpreter. So you have to negotiate with them. Most of the time when I talk to them, I tell them, okay, all of us, we speak English, right? The problem is the medical lingo is difficult to understand. My concern is that you're listening to a conversation with the doctor. There's a word that you don't know. You start to wonder, what is this? When you come back, you lose track of the conversation. So let me help you, and you do your part, which is taking care of your loved one and listening. So you can take any decision and do whatever is needed. Right? The CCM goes on to say that usually puts people at ease. People then don't get offended. They work with us and they do really participate in a better way to do the treatment of the patient. So I think, you know, some of the things that are highlighted in this quote, one is establishing a shared goal, right? The shared goal here is to provide high quality care, patient-centered care, to take the best care possible of the patient. And in order to do that, the interpreter can help by offloading some of the burden, right, or the challenge of, as a family member, doing two things simultaneously: one, acting as an interpreter; two, listening to everything that's been said, processing everything that's been said, supporting the patient, you know, and the rest of family members, if there are other people there. So the interpreter can kind of come in, offload that burden, and help in this shared goal of providing the best care possible, right? By supporting this family to make the decisions that make the most sense, now that they're able to kind of fully understand what's going on and to be able to have that time to process what's being said instead of trying to be interpreting at the same time. All right, some other best practices as we think about working with interpreters. So as we emphasize in goals of care communication in general, having the importance of a pre-meeting, right? We talk about how all the members of the team who are going to be present for this conversation, you want to make sure that they're all on the same page. The interpreter is an important part of that clinical encounter as well. And so in pre-meeting with interpreters, one, it gives you the chance to tell the interpreter what the purpose of this conversation is, and to kind of give them a heads up, particularly to any challenging or kind of difficult things that you as a clinician are going to bring up in this conversation, or that you think might come up, right, from the patient and family. So really helpful to give the interpreter a heads up about those things. Also gives you a chance to just kind of review some of the basics of the patient's condition. So a really helpful thing when the interpreter is kind of interpreting specific things is for the interpreter to have that overall context about what is going on with this patient. So again, this pre-meeting gives you a chance to review some of the basics of what's going on with the patient and kind of where we're at right now before the conversation. Then it gives you a chance to ask the interpreter if there are any relevant cultural norms or practices or terminology that would be really helpful to facilitate this conversation. So it's a two-way street. You're giving information to the interpreter, you're getting information from the interpreter that would be really helpful in having a better conversation. And then the importance of debriefing with the interpreters. This is probably the thing we do least frequently. And I think both the pre-meeting and the debrief are really important, whether this is an in-person conversation or, as we've had over the last year, a Zoom conversation. And oftentimes when we're using Zoom, we forget about the role of these two things. So I think this is really important to be thinking about even in that context of the video interpretation. Debriefing provides you an opportunity to provide emotional support to the interpreter. So, we think about some of these conversations are so heavy, they're high stakes conversations, there's a lot of emotion that's going on. We walk out the door, we're often debriefing as a team, and the interpreter is kind of like left on their own, right? And the interpreter may have a pre-existing relationship with this patient and family. So there are a lot of reasons why, that emotional content of the conversation may, be pretty heavy for the interpreter as well. So I think debriefing gives a chance to also provide emotional support to the interpreter, thinking again of them as a member of the healthcare team. And it may also provide a chance to provide feedback. I mean, in one of the studies where they interviewed interpreters that I presented earlier, right, we had talked about how they described rarely receiving feedback from clinicians. And then I talked about the kind of before and after, and we're getting kind of near the end here, talk about a couple of things during the discussion itself. So the first here, again, I think this is kind of obvious, avoiding medical jargon, things like speaking in short sentences, really helpful when you're working with interpreters. I talked about the challenges with some of the terminology that we use in palliative care, things like do not resuscitate, hospice, even the word palliative care. Even if those terms, sometimes those terms don't have translations in different languages. Sometimes they do, but they mean something different in a different language. And so really trying to spend time on explaining the underlying concepts of those terms and focusing less on those terms themselves. Using empathic statements as you normally would. Again, I talked about that data where people were actually cutting out the emotional component, emotional support component of conversations when they were using interpreters. Speaking directly to patients and family members, using in-person interpreters if possible. Again, as we think about the context of palliative care, we're talking about pretty tough conversations. And I think another strategy in dealing with, some of those alterations we found that were happening in interpretation is to check for patient and family member understanding. So, having patients and family members kind of talk back to you about what they're taking away from what you're saying. Another really effective way to make sure that what you're trying to communicate is getting translated. Okay, so this is my kind of transition to mention the Harborview CCM program that I'd mentioned, and to talk about that, I really focused heavily on issues around interpretation. But there are a lot of other issues, thinking back to that graphic in the beginning, right? All the multi-level barriers that patients with LEP are facing. And so as we're thinking about interventions, interpretation is critical, right? Hopefully I've made that case to you. Interpretation is critical. But likewise, there's an importance to think about advocacy, education, and that's both to the patient family, about the Western healthcare system, to the healthcare team, about cultural values and norms, to the community, a need for assistance with care coordination, navigation, and cultural mediation. So here's a shout out to what I think is a fantastic program, the CCM program at Harborview, which then kind of takes that concept, right? Not just providing interpretation, but providing those additional really important elements to provide the highest quality of care possible for patients with LEP. And I think, is really a model for the kinds of interventions we need to be thinking about for these populations. So final takeaways here as we're nearing the end of our time. And I know I saw that at least one question was there, so I do want to make time for that. So what I want you to walk away with this from this talk with is that patients with LEP are at high risk for poor quality care. That's because of multiple factors, including not using interpreters enough, the role of language barriers on communication, especially about things like goals of care, and the role of language barriers on other aspects of care. Remember to use an interpreter, and then follow some of those suggested practices I had for how to work in partnership with the interpreter. And then, as I said, a need for thinking about interventions that go beyond interpretation to really address these inequities in care for this population. So on that note, I will open up for questions. I know I had seen a hand up previously, and Alice, maybe I'll turn it back over to you to kind of moderate the question part for these last few minutes.
Sure. Oh, go ahead if you have a question. If you have a question, feel free to unmute yourselves or type it into the chat box. There's been some great discussion in the chat box with suggestions from other participants. Thank you for that.
Hi, Rashmi. This is Amy Trowbridge. I'm one of the palliative care docs at Children's. Thanks for this. I was curious if in your sort of outline of pre-briefing with interpreters and then debriefing with interpreters, I totally agree with you. I'm pretty good at the pre-briefing, but forget to do the debriefing often. And I'm wondering, you mentioned kind of providing feedback to them. Have you been successful in kind of getting your own feedback about, words that maybe you used that you didn't realize, or have you ever tried sort of eliciting feedback from interpreters themselves as kind of a back and forth there?
Yeah, great question, Amy. A little bit, and I would say that in my own experience, I think I've observed kind of a hesitancy for interpreters. And I think this probably depends on how experienced they are as well, right? And their kind of confidence level in providing feedback. But I think, as we think about kind of the good communication skills for palliative care clinicians, this idea of, that was a tough conversation. I always want to make sure that I'm getting better in navigating these tough conversations. You have any feedback for me on things that I could do better next time, with a patient who speaks this language or from this community, or I think in general, like that kind of approach, right? Like, I want to get better at this. The interpreter is usually supportive of the idea of like clinicians being more sensitive to things. I've also found that some, again, I think this varies from person to person, but that opportunity of, that kind of cultural humility, like, I would just love to learn from your perspective about what are some of the cultural practices that are really important, or norms, or I find that's another question that people can really have a lot to say about, right? Like, they like the opportunity to educate you as the clinician about their community. And so I think those are kind of some strategies that can work well.
Okay, and we have another question from Elena. Do you have any resources on how I can integrate this into orientation for ICU nurses?
Yeah, so that's great. And I realized that I had the website up and I didn't kind of call attention to it. There's the Ethnomed website through the University of Washington that has a lot of great resources for different communities, and thinking about some of the content or history that's really relevant as you're working with specific communities. It also has a section on end-of-life care and other clinical topics. So I think that can be a great resource to take a look at. I can, maybe if I'm quick enough, I can even put oh great, thank you, Alice, for putting the link in the chat box. So that's something that I would recommend as a starting point.
And Ruth is just echoing that the CCM program at Harborview is great. Does anybody have any other questions? Because it is 1, so if it's okay, feel free to email me any questions you think of and I can pass those along. I will move on to the next session.
Thanks.
Thank you so much, Rashmi.
Thank you.
Okay. And actually, while the next, right before I introduce the next speakers, I would love to get everyone's feedback. We are currently planning the 2022 Pacific Northwest Palliative Care Conference, and I want to understand if folks would be comfortable attending this in person. So if you could respond to the poll really quick, that would be much appreciated. And so our next speakers are Doctors Jennifer Kett and Arika Patneaude from Seattle Children's Hospital. Dr. Kett is a physician and bioethicist who is board certified in neonatology as well as hospice and palliative medicine. She is the interim division chief for the Division of Bioethics and Palliative Care at Seattle Children's. She specializes in the care of children with a wide range of life-limiting and life-threatening illnesses. Her current research focuses on medical decision-making for infants and children. Arika Patneaude is a clinical social worker and an ethnic minority mental health specialist who has been practicing in Seattle since 1992. She is a clinical instructor through the University of Washington School of Social Work and director of bioethics and palliative care at Seattle Children's. Arika is the founder of and a consultant for More Genesis Consulting Services, which provides consultation to area programs on engaging in culturally responsive practices across settings. Thank you so much for joining us, and I will turn it over to you.
Great, thanks, Alice. Just one question. Are you going to pull up the slides and make us co-hosts so we can advance them?
Yeah, so you guys are both co-hosts right now. You should be able to advance your own slides. If you go to the little green up arrow at the bottom of your screen, you should be able to share.
Okay, sorry, we misunderstood. We thought you were going to have the slides pulled up for us.
I can have it pulled up. Do you want me to do that? And you can just tell me when you want me to advance?
Yes, please.
Okay, all right.
Thank you.
Yep, sure, of course. Oh, sorry. Folks, 1 second. Let me bring up the PowerPoint. That is much more attractive to look at.
Well, I'll just get us started by saying we're really excited to be here today. Arika and I had big plans for this as an in-person workshop back when we thought about such things with optimism. And Arika, do you want to tell everyone how to pronounce your last name?
Sure, it's Arika Patneaude.
Oh, okay. Thank you, Arika. I'm so sorry about butchering
No problem.
that.
No problem, I'm used to it.
And we've sort of adapted a workshop that I've given in person a few times to be reasonable in an online world. So we hope you'll find it interesting. It's fairly interactive, so please do feel free to turn your videos on. We will be kind of walking through a case together.
Okay, can everyone see the slides okay?
Great.
Okay.
And Alice, just go with your gut. I feel like it's going to be pretty obvious when to change slides.
Okay.
Awesome. So our objective is to really focus on a case, to think more deeply about the unique challenges faced in pediatric palliative care.
Oh, sorry about that.
I like it. Cool view. And we'll talk through some of the ways that transdisciplinary team members are really important for overcoming some of these challenges and discuss some systems issues that can be barriers to success. So what's going to happen? You're going to hear some details of a case. At each decision point in the case, we're going to kind of take a vote, kind of poll the audience. There'll be options in the poll, you make your choice, and we'll have a short discussion at each decision point about kind of what brought you to the option that you chose. This is what the decision point slides look like. They're this beautiful mustard color. That's Arika's favorite color. You're going to say, we're going to give you the decision that the family's made. You're going to say, I agree with the family's choice and I'm going to support them. I disagree with the family's choice, but I'm going to support them. I disagree with the family's choice and I'm going to talk about it with my team. I'm going to let my team know how I feel. I disagree with the family's choice and I'm going to tell the family how I feel. I'm going to have a conversation directly with the family about why I disagree. There are always folks who are like, I can't choose between B and C, or I can't choose between C and D. This is a day to just be decisive. It's just an exercise. Go for it. Choose a letter. A couple disclaimers. This case is fictional. We completely made it up. It can be a little intense for those who've experienced a recent loss. So if you're not here for that today, please, we won't be offended if you hop out of this workshop. We're also not oncologists, so if there are oncologists in the audience, bear with us. And all of the photos are stolen from the internet. So this is the story of Sophia. She's a 6-year-old girl. Her parents are Anita and Ivan. Sophia loves princesses, especially Disney's Rapunzel. She started kindergarten this year and she loves school. She has no siblings, but she spends a lot of time with her cousins. She's very close with them. And Sophia has a dog named Sock. And here we have Sock. For the past 2 months, Sophia's been having headaches. Sometimes ibuprofen helps, but sometimes it doesn't. Her parents took her to the PCP who thought that it was allergies, and Sophia was started on Claritin. The Claritin didn't help very much, and on Tuesday, Sophia's head hurt so much that she didn't want to play with her cousins. Her parents also noticed that she's been kind of clumsier than usual, and today she started vomiting. Her parents brought her to the ER for evaluation. And here we have Sophia in the ER. In the ER, they do a scan, and this is what it looks like. There's a massive posterior fossa tumor. And it's revealed to be probably medulloblastoma. This is the most common malignant brain tumor in children. 80 to 90% of those without disseminated disease can be cured. It has a pretty reasonable outcome if it hasn't disseminated. Treatment does often result in long-term neurologic sequelae that can be kind of unpredictable and over a wide range. Sophia has neurosurgery pretty urgently. The tumor can't be completely resected due to its location, and she's brought back to the peds ICU on a ventilator to recover. And here she is. Unfortunately, she has evidence of CSF spread. The oncologist determined that her tumor is high risk based on the pathology, and the 5-year survival rate for her is actually estimated to be only 30 to 60%. The oncologists recommend going forward with chemotherapy and radiation, the standard treatments for this disease. And so here we are at our first decision point. Sophia's parents decide to go forward with chemo and radiation, knowing the prognosis and the inherent uncertainty there. Please vote in the poll. I agree with the family's choice. I'm going to support them. I disagree with their choice. I'll support them. I disagree. I'm going to tell my team. I disagree. And I'm going to tell the family. I'm very relieved the technology is working. Looks like we've got a few more folks who haven't voted yet. All right. Well, as expected, 100% of us agree with the family's choice to go forward at this time and to proceed with chemo and radiation. Is anybody willing to share their thoughts about why they chose choice A? Why this seems so straightforward and reasonable?
We might have to start calling on some of the folks in the audience that we know.
We got folks in the chat. First of all, Amy Trowbridge also loves mustard color. That's fabulous. Amy's saying pretty good odds. She's a child and she has a good chance to live, from Ruth. Elena says, I don't have children, but if I did, I'd want to try what I could. Beautiful. Any other thoughts? Other folks agreeing? Great. Straightforward from here. All right, Arika, I'm going to turn it over to you.
Great, thanks. So for the next slide. So Sophia, she fails several attempts to be extubated. An evaluation reveals that she has vocal cord paralysis, and it's likely a complication of neurosurgery. It's not clear whether or not this will improve in the future, and the ENT consultant has recommended a tracheostomy. Next, please. The ENT consultant describes the risk of the trach, and she describes it as care. She describes the care that will be required in the home. And still, Sophia's likelihood of survival is still 30 to 60% with chemo and radiation. Next. So here's another decision point. Sophia's parents decide to go forward with tracheostomy. So again, please use the poll to vote with whether or not you agree with the family and support them, whether you disagree but will support them, whether you disagree with their choice and will tell the team how you feel, or whether you disagree with the family and will tell the family how you feel. And so far we have about 70% of folks who have voted, and all so far 100% are choice A, agreeing with the family's choice and will support them. Is anybody willing to share their thoughts on this? Either in the chat or to unmute and share with us.
Hi, this is Brittany. I think while there's no way that the family can fully understand what their life will be like if their daughter has a trach, I think that things are similar to before, where there may be unanticipated outcomes, but our hope is that she has a good chance of survival. It seems reasonable to try to treat the cancer.
Thanks, Brittany. And Elena says in the chat that trachs aren't permanent, so would still hold out hope. And Megan says it's unfortunate, but it can be lived with while having joy and fun and quality of life. And I would want to give my child that opportunity. Amy says it's an uncertain prognosis for VC paralysis, also still a decent chance of long-term survival. Susan says similar, still a good chance for survival and quality of life with a trach, and that she had a brother living with a trach. Ruth says that she's usually biased in terms of less intervention, but again, this is a child and she may be able to have a good quality of life. And Jennifer, as a parent, I'd want to work toward the potential that I could have some communication with my child with hope that the trach would allow for this. Thank you all for your answers.
Perfect. Oh, we got Shannon saying they're hopefully aware of all the risks and benefits. I'm still there to be their advocate, still a chance of survival. Sometimes a couple folks are like, trachs are so burdensome, it would be so difficult, and she's probably gonna not survive anyway. And so I really feel a little uncomfortable. But we don't have any folks in the group today who feel that way. So Sophia undergoes her tracheostomy surgery. She has a reaction to the anesthesia and she arrests in the operating room. She's resuscitated and she receives 22 minutes of CPR. She's returned to the peds ICU and is stabilized. She does not receive a trach. And here's her MRI, which shows, you can move on to the next one, Alice. Diffuse hypoxic ischemic encephalopathy. She remains intubated in the ICU and she starts having seizures. Neurology is consulted and assists with seizure control. They explain that her neurologic prognosis is really unclear. She's very likely to have some lasting deficits, but they could range from more mild learning disability, difficulty with coordination, to being nonverbal and spastic, having spastic quadriplegia. The impact of chemo on her neurologic recovery is unknown. So at the same time that her brain would be trying to recover from this injury, she'd be getting intensive chemotherapy. And here's Sophia in the ICU. After 2 weeks, Sophia is stabilized enough to discuss the plan going forward. One option would be to continue with the planned tracheostomy and chemotherapy as the plan had been before. Her likelihood of survival is still around 30 to 60%. Her risk of neurodisability is high, but the severity of it is completely unknown. The other option is to withdraw life support at this point. Middle ground options were also discussed in detail, waiting more time to allow neurologic recovery. That has the downside of allowing her cancer to progress. Tracheostomy without doing chemotherapy so that she could go home. Chemotherapy without doing tracheostomy was really not recommended because of the sort of long-term need for her to stay intubated, which would be pretty uncomfortable. Sophia's parents decide to go forward with the trach with chemo and radiation as they had originally planned. Please let us know how you vote. Starting to get some folks breaking away from letter A. Oh, Ruth is saying, can you put the poll up again? I still have it up. Elena's saying it's starting to get uncomfortable. Anybody who moved on to letter B or letter C want to share in the chat what made you start to have some disagreement about the family's choice? Carrie saying definitely between A and B, but chose A. It's starting to be a tougher choice. Anyone willing to share why they didn't choose A? Or Carrie or others, what made it harder? Elena's saying I'm stuck because the neuroprognostication worries about sort of neurodevelopmental outcome. Jennifer saying the opportunity to give a little more time was more attractive to me, but it's really hard to anticipate how I might feel in this situation. Absolutely. Dee Pierce is saying, I did choose A, but as someone who works with adults in oncology and palliative care, this is really making me reflect on how age and life experience shapes my perspective about patient and family decisions. Reflecting already, gold star. Amy, my choice would have been wait a bit more for more neuroprognostic info before deciding on a trach. Fabulous. Any other thoughts folks have before we move on? Folks who were in A, what made you stay in A? Oh, Ruth, definitely tougher. I think I'm in B now. All right. Well, let's see how it evolves. Brittany, felt like a time-limited trial to me. Amy, 2 weeks out from hypoxic injury, too early to know how much. CYNSES is saying hope. Other options did not seem as hopeful. Amy agreeing with Brittany. Fabulous. All right, Arika, back to you.
Thanks, Jen. So she receives her tracheostomy and recovers uneventfully. Chemotherapy is started. Her neurologic status remains very limited, although she has started opening her eyes at times and appears to respond to her parents' voices and touch. And here she is getting an exam. So Sophia becomes neutropenic from chemo. She develops a fever and is started on antimicrobials. She develops worsening respiratory distress, and her blood cultures are positive for Candida albicans. She develops multi-system organ failure. She's believed to have fungal sepsis and meningitis. She requires vasoactive infusions and begins to have bleeding from her tracheostomy site. So the PICU and the ONC teams meet with Sophia's family. They compassionately explain that her outlook is grave. She's unlikely to survive this infection, and if she does, she will likely have additional neurologic deficits. And additionally, her neurologic recovery had been very minimal. The team suggests to the family that they withdraw life support and allow Sophia to experience a natural death. So I think many of us have probably found ourselves in this situation, right? Where her parents do not wish to withdraw life support. They understand that the odds are against Sophia, but they explain that they can't and won't give up on their little girl. They explain that family and friends from across the country are praying for Sophia and that they're hoping for a miracle. They show the team photos of Sophia from before her illness to show the team who she was. And here she is again. So we're at another point for us. Sophia's parents do not agree to withdraw life support. So as a member of the team, do you agree with the family's choice and you'll support them? Do you disagree, but will support them? Do you disagree with their choice and will tell the team how you feel? Or do you disagree with the family's choice and will tell the family how you feel? So with about 40% of folks now about 50% of folks having voted, we're starting to it's starting to change from A to B. And then a couple of people have voted C. What thoughts are people having as you're voting? Imagining this situation. And you can put your thoughts in the chat, or feel free to unmute yourself. I'm curious about the 12 people who have voted B, that you disagree with the family's choice, but you'll continue to support them. And for those of you who voted C, you disagree with the family's choice, and what will you say to your team? So Shannon says, disagree but support them. I can't force them through their stages of grief. Very good point. Elena says, seen this too many times with adults and don't know if I could bring myself to torture Sophia. CYNSES says, I'm their advocate and it may take them time to move to a different place if at all. D. Pierce, as a social worker, it is my role to provide support and to not let my personal thoughts interfere with their grief process. So a couple of folks are saying not to interfere with their grief process. Susan, ultimately, I would support the family, but would definitely need to discuss with my team for support. Brittany, it's impossible to know how I'd feel for sure, but with my experiences, I imagine that I would not make that choice for my own child. I believe it is important to give the family more time so would still support them. Ruth, I think she likely is now suffering, which has changed my perspective. I think there is a futility to it now. I would talk with my team in the interest of communicating so that we can debrief and still try to provide the best care. Jennifer says it seems like she is experiencing some more potential for suffering, but hard to determine how this family identifies suffering. It's a good point, Jennifer. Still in the supportive space with them, exploring their perceptions. And I think that's a really important point because, I'm also thinking about this, about cultural variables that may impact how a family views suffering versus how we as providers view suffering. Amy says, sounds like this family is making an informed decision based on values of longevity, not what it might choose, not what we might choose, but I would honor their values. Oh, Carrie, I'm sorry, your computer keeps freezing, but Carrie says she chose B and agree with everyone above. Your turn, Jen.
Sophia continues to worsen. The ICU team lets Sophia's family know that they do not have any other therapies to offer that they believe will help. They will not be able to escalate therapy. They will not provide CPR as it won't be effective. They'll focus on keeping Sophia as comfortable as possible. Sophia's family is very sad to hear this, but they express understanding and they're amenable to this plan. They have her cousins visiting at the bedside daily. They sneak in her dog Sock to provide her some comfort. They play Disney's Rapunzel continuously in the room. They cry. They look exhausted and overwhelmed. They speak to Sophia and tell her how much she is loved and how sorry they are for letting her down. Sophia's parents do not want to withdraw life support, but have agreed not to escalate her care any further. Give us your vote. All right, those who are willing to share in the chat what brought you to A or B, let us know. Megan, recognizing that as a clinician, I'll likely see the big picture coming down the road clearer and sooner than families or non-medical folks do. And I try to consider that in the timeline of decision making. Jennifer saying, this family is on a grieving, letting go journey, and I support their decision as an increment of this process. Any other thoughts? Hardest part is now, what do you mean by agree, disagree? What we would choose for ourselves or what we think the family should do. It's a great point, Amy. I am A. Eventually what will happen, and at least they're not arguing for more aggressive therapy. In for the long haul, they have to play it out in their own time frame. Carrie saying the A and D choices are both ringing true, but rather than tell the family how I feel, I may choose to explore more with them, or B and D rather. Yeah, that's a great point. All right, Arika.
So one night in the ICU, Sophia's heart rate begins to fall. Her parents are present at bedside, and they ask if they can hold her without all of the machines. With the physician's approval, her nurse and her respiratory therapist remove Sophia from the ventilator and place her in her parents' arms. They provide her with morphine and Versed for comfort, and she passes away peacefully. Her parents thank the team for their kindness and care. The ICU social worker walks them to their car. And here's Sophia again. And Alice, maybe, yeah, we can stop sharing now. And as we reflect on this case that, as Jen said at the beginning, that was made up. But I know for me as a palliative care social worker, feels very familiar. What comes up for for all of you at each of these decision points, or what came up for you, each of you. And feel free to unmute or put your answers in the chat. So looks like, Carrie, you put in first extreme gratitude for those of you who choose pediatric palliative care and provide healing to those families. Jennifer says, I have an only child named Sophia, so it got personal very quickly. And Jennifer, I think, you know, you're pointing out how transference or countertransference can happen quickly in clinical situations. And can introduce bias, whether good or not so good, right? And Elena says, it's hard for me because I am not a mother and have had lots of experience with taking care of patients with a futile diagnosis, trying to put myself in others' shoes.
Someone else is saying, these are all difficult decisions at each stage, especially as the prognosis becomes more dire. I had to remain firmly focused on the idea that it's not about them and not me. I think one of the reasons behind this exercise is for us to see the way in real time as a case unfolds, we're all having these different thoughts. Judgments is probably too strong a word, but these sort of assessments that are going on kind of behind the scenes in our brain. Do I agree? Do I not agree? Even if we're not sort of explicit about it. And as we're doing that, so is everybody else on the team.
Mm-hmm.
And you can see by the poll and by the comments, we're sort of all doing that at sort of a different rate and based on different things. And so that's all happening behind the scenes as sort of a team dynamic. And so one of the takeaways we hope that folks will have is that it's really complicated. And at any given time, I may not agree with the family, or I may agree with the family, and everyone else on the team may feel totally different. And it's so rare that we're kind of explicitly talking about that, particularly at some of the smaller decision points.
A couple more.
Yeah.
Oh, sorry, Jen. A couple more comments in the chat. So Heidi says it's difficult to separate your thoughts as a parent. I would have done everything the parents did if it was me in that situation. And then Susan says, as a mom, I definitely had a lot of emotion come up. As a nurse, I understand the clinical picture and how the parents must have been feeling. Challenging to separate mom-nurse roles. So true. And I think about, you know, times that cases like this, at least that I've experienced, cases like this can really induce a lot of distress among team members. And in particular, thinking about our bedside colleagues who are spending long shifts, you know, 8 to 12 hours or more at bedside with a patient and a family who is experiencing this.
And I just want to come back to Amy's, I think, very astute comment in the last decision point, which is I'm not sure if I'm supposed to be voting based on if I think this is the right thing for me, if I were in their shoes, or if I think this is the right thing for them as someone who's been asked to advocate for them. And I would just love to hear folks' reflections on sort of how we keep those things separate. Should we keep those things separate? Where those things kind of blur and come together?
So just going back to chat with Ruth saying that she's not a parent and it was still emotional and sad. It's so hard to understand why these kind of things happen to such a young child. You know, the unfairness of it.
Yeah.
Right. And then Amy says, I really appreciate the comments about the pace, and pace being capitalized, at which we all come to these decisions, including the family. Right. And sometimes as the providers, we might be quicker to come to the decision because of what we know, or because we're uncomfortable in sitting in that hard space with families. Whereas for families, they're making decisions that will impact them for the rest of their lives.
Yeah, Arika
okay.
and Jen, I was just going to add a comment to that. I think this case is like the way it unfolded is so realistic. Brittany and I were texting about the least realistic part was when the team actually said they wouldn't do CPR, but that in the end the family sort of made that decision on their own. And I feel like in reflection on your question, Jen, that that along the way, when we notice ourselves getting farther ahead of families, like we have this very altruistic worry about, oh, but I can see what's going to happen and this family might regret it, right? And I need to help this family see where I am, what I can see, so that we can protect them from this regret. And it is such an altruistic desire on our part. And it almost never works, right? To try to get a family further ahead than where they're at. And we, too many times we can see that push ends up kind of forcing families to dig their heels in more where they're at. So really cool, guys.
Yeah. Great point, Amy. And I also, I think about, for those of us who are on this call who have done bereavement support with families or bereavement therapy with families, that families constantly, like, nothing we do can control the impact on a family's bereavement. And like, we might think that we can, right? Like, oh, if we just get them the right legacy items, or if we just do this or we just do that, we might make them feel better. But the reality is that in bereavement, that each family has their own journey, each individual within the family has their own journey, and there is nothing that we can do to, quote unquote, make it better for them.
I'm curious if after going through this exercise, folks have thoughts about how they might team differently, or be more attentive team members, or more, or just change their behavior as a team member, for their thought process.
Jen, I'm reflecting on, I guess, your question and Amy's comment on actually how we might consider that same process for team members. And I'm a PhD fellow, for those who I don't know, so I have experienced this situation a number of times in my short years of doing this. And I think I oftentimes forget that some of those same colleagues, like a newer bedside nurse who's starting out their career in the ICU or on the cancer care floor, may not have experienced this. And I think I often forget that, and pausing to reflect and even just debrief, I think, can be really helpful I know that was helpful for me as I was like a pediatric resident, folks taking me through what this process looked like. And I think that we can benefit from those shared experiences and having those discussions with our team members.
Jennifer's saying, I think that point in time where the space between what would we do and what the family choosing grows apart, that's the time to pay close attention to how our values might start to interfere with our ability to support the patient and family with the pace of decision making. I think that's such a great point, Jennifer. That's a place where our values, our great values, our
discomfort,
judgments, our awful biases, they can start to really sneak in. And I'll also say the data really reflects what Amy has said, which is that trying to push families to decision-making faster than they are ready for, before they sort of see the changes that we're anticipating, really can backfire. And it doesn't work at all. And it provides a lot of distraction and unnecessary entrenched conflict, and probably prolongs the timeline, although that's not been described as well. The other data is that when physicians who say, I would never want this, at the end of life, I just want to go home, we choose to die in the ICU, intubated, getting CPR at the same rate as the general population. Oh, Ruth has something good.
Yeah, so Ruth says, this is so crass and not altruistic at all, but sometimes I see what seems to be a medically futile situation and think about all the medical resources and money spent on the patient situation. That's where I struggled with the patient being maintained on life support when everyone knew she was dying. But on the other hand, the family needed time to say goodbye. Tough stuff. Yeah, Ruth, I think I always think it's good to discuss the good, bad, and the ugly. So I don't see this as being crass. I think that, it's not just, I don't think it's just the clinicians in this case, but it's also the administrators, right? So if a family takes quote unquote too long, and especially in the state that we're in right now, where beds are at a minimum, thanks to COVID. And thinking through, like, okay, if we know that a case is futile, and we know that there are patients being diverted, or there aren't beds available, how do we do this? And that can also make it very sticky and difficult as well.
Thank you for naming that, Ruth, because I also think what can happen on a team is that folks are having thoughts about resource allocation and sort of the unfairness or stress or tension around it that they're either afraid to say, or sometimes people will only talk about the resource allocation issue, and what they really mean is, I'm very troubled kind of morally by what's happening here. But they'll focus on we need this ICU bed, we need this ICU, ventilator, what's happening. And so kind of holding both at once, I think, is super important. Megan's saying it's helpful to share with the team what personal preferences or opinions come up so that we can recognize where we may be experiencing dissonance. I think that's so true. In my ICU, I heard so many of my coworkers say things like, this is ridiculous. I can't believe the family's keeping him alive. And I thought to myself, I would keep trying to keep him alive too if it were my son, if I'm being honest with myself. What a fabulous point. And Amy's agreeing with you that it's fabulous. I think that's really, really true. And I think we're just at the beginning, I think, in palliative care of starting to pay a lot more attention to our own responses, our own sort of self-regulation, our own background judgments that are happening, and kind of thought processes that are happening unconsciously behind the scenes, and how that may impact our care with patients. And so some of our other colleagues may be way behind in kind of thinking through some of that. So I really appreciate the reflections. Any last thoughts? I think we probably don't need the full hour, but any last thoughts or reflections or questions or concerns that folks have?
Can you see yourself doing potentially like a case review or something like that with your team, talking through these points? Absolutely, thank you.
Yeah, I think the more we can sort of raise up the issues that are operating without our knowledge to kind of the visibility, so we can talk about them and unpack them, it can be really helpful. Ruth is saying this was great. Thank you. Any other questions before we, Carrie, are you raising your hand? Oh, like a physical hand raise? It's like old school, itchy palm. Well, I think we all thank you for your kind attention and your willingness to kind of engage around this. And Jennifer, I know is particularly heavy for you. If other things come up, Alice has our emails. So please don't hesitate to reach out. Thank you all for your kind attention.
Thank you so much.
And thank you, Jen and Arika, for joining us. That was a really great presentation, and I got a little bit misty. One last thing is I've dropped the course evaluation for everybody into the chat box. I will also follow up via email. And one last quick thing is, if you are part of the UW, we have access to lots of resources through CPCCE. And you can follow the directions on the screen to log in. The CAPC membership is partially sponsored by Cambia Health Solutions. And that is it for me today. Thank you so much and have a great Friday afternoon.
Thank
Thanks,
you so much, everybody.